Welcome to All in All. Today we are taking a deep dive into the world of kidney basics, specifically tailored for you as you prepare for a dialysis registered nurse position. We're going to unpack some foundational concepts, understand how the healthy kidney works its magic, and then really focus on what you need to know clinically when that system needs support, which, is where dialysis comes in. Think of this as building your essential knowledge base, starting from the outside and working our way in all the way to sitting bedside with a patient on dialysis.
Absolutely. It's crucial to have that strong physiological foundation. Understanding the kidney's normal function is really the lens through which you'll view every patient assessment, every treatment decision in the dialysis clinic.
Okay, so let's start with the kidney's physical place in the body. How is this vital organ actually held in place and protected? It's not just like floating around in there, is it?
Yeah, no, definitely not. It's quite cleverly secured and shielded. Think of it being nested within layers.
Yeah.
Outermost, you have this dense, irregular connective tissue called the renal fascia.
Renal fascia, okay.
It acts like a tough anchor, holding the kidney in place against the muscles of your posterior abdominal wall and separating it from surrounding structures.
Got it, so it's anchored. And under that layer?
Under that, there's a pretty thick layer of fat, the adipose capsule.
So fat.
Yeah, this layer acts like protective padding, cushioning the kidney from any physical shocks or, impacts.
So fat isn't just storage, it's also padding for organs. Interesting.
Exactly. And here's where you see a direct clinical connection to overall patient health. During prolonged starvation, the body can actually start to use the fat in this adipose capsule as an energy source.
Really? Uses that specific fat?
It can, yeah. And when that cushion disappears, the kidney can actually drop lower than its normal position.
Oh, wow. So malnutrition can physically cause the kidney to droop. What's that condition called?
That's nephroptosis. Nephroptosis.
Nephroptosis.
It's a clear example of how systemic issues can directly impact organ placement and function. It really highlights why a thorough patient history is so important.
That's fascinating. A physical manifestation of nutrient depletion right there at the organ level. Now let's zoom in, way in, past the outer layers, to the microscopic workhorse of the kidney, the nephron.
Right, the nephron.
Yeah.
This is the true functional unit. Each kidney has millions, literally millions of these tiny structures. Their primary job? To process the blood that flows through the kidney, filtering it, reclaiming what the body needs, secreting waste products, and ultimately producing urine for excretion.
It's like a miniature, incredibly complex filtration plant and recycling center all rolled into one, and the very first step is filtration, right?
Precisely. Blood enters the nephron and is filtered through a specialized structure called the filtration membrane.
Oh.
Now, what's truly remarkable here, really amazing, is the sheer surface area involved. In just one kidney, if you added up the surface area of all those tiny filtration membranes across millions of nephrons, it would cover about 6 square meters.
6 square meters? Are you serious? That's like the size of a small bedroom floor, all packed inside your kidney.
It is. And that massive surface area is key to making the filtration process incredibly efficient. Extremely efficient.
So it's just designed for maximum contact and speed right from the get-go. What actually makes it through that filtration membrane? What gets filtered from the blood into the little tubule?
Well, the filtrate is essentially blood plasma, but without the big stuff.
Big stuff.
Yeah, like blood cells or large proteins. Those stay behind. So the filtrate contains water, obviously, all the important ions like sodium, potassium, calcium, chloride, bicarbonate. It also includes valuable small organic molecules like glucose and amino acids, and importantly, the metabolic waste products we need to get rid of things like urea, creatinine, and ammonia.
Okay, so the filtrate is like a raw version of plasma, full of both good stuff and bad stuff, ready for processing down the line. Speaking of processing, how do we even measure how well the kidney is doing this job of filtering? How do we assess function?
The most common way we assess kidney function starts with looking at creatinine levels in the blood.
Creatinine.
Yeah, creatinine is a waste product generated by normal muscle metabolism, and healthy kidneys are really good at filtering and removing it from the blood.
So if it's high in the blood, that usually means the kidneys aren't clearing it effectively. Something's wrong.
Exactly. Generally speaking, a plasma creatinine level above around 1.2 milli-GDL can indicate impaired kidney function, though that number can vary based on muscle mass and other factors. We often use creatinine levels to estimate the glomerular filtration rate, or GFR.
GFR, that's the key measure, right? Like the overall speed or volume of blood being filtered per minute?
It is the key clinical measure. But here's a crucial point for you as an RN. Relying solely on serum creatinine to estimate GFR has a significant limitation.
Oh, what's that?
Well, a substantial portion of the creatinine that ends up in the urine, anywhere from maybe 15% up to 50%, isn't just filtered at the glomerulus, it's also actively secreted into the tubule later on.
Ah, so the tubule can actually add creatinine to the filtrate after the initial filtering.
Yes, exactly. And because of that secretion, someone could have a GFR that's actually declining, their kidney function is getting worse, but their blood creatinine might still appear relatively normal because the kidney is compensating by secreting more creatinine into the tubule.
Huh. So it can give a misleadingly normal picture even when filtration is actually low.
Precisely. It can mask a decline in true GFR.
Okay, that's a really important insight.
Right.
Serum creatinine isn't the whole story, not by a long shot.
That's why we increasingly rely on calculated or estimated GFR, or eGFR, using formulas that factor in age, sex, and sometimes race, though the race factor is being reevaluated and removed from many equations now. The standard definition for chronic kidney disease, or CKD, is an eGFR consistently less than 60 millimoles per minute per 1.73 square meters of body surface area.
Less than 60. Okay.
And the field is also exploring newer biomarkers, chemical signals in the urine or blood that might be more sensitive than just BUN or creatinine for detecting early damage.
Newer biomarkers, like what are we looking at?
Things like KEAM1 and NGL. KEAM1 is kidney injury molecule 1, and it seems particularly sensitive for detecting damage specifically to the proximal renal tubule cells.
Okay. And NGL.
NGL, neutrophil gelatinase-associated lipocalin, is often looked at as a biomarker for acute kidney injury, API. Although it's worth noting, it can also be elevated in more general inflammation, so it's not perfectly specific. But these offer potential for earlier detection of kidney stress or damage.
More sensitive tools give us a better chance at early intervention. That makes sense. Let's follow that filtrate now. It just got filtered. It's full of water, ions, glucose, waste. Where does it go first?
The proximal tubule, right. You mentioned this is a major site for reclaiming things.
It's incredibly active. The proximal tubule is where the bulk of the necessary substances are pulled back from the filtrate into the bloodstream right away. It even has slightly different structures depending on which type of nephron it's part of. There are superficial ones closer to the kidney's surface and juxtamedullary ones that extend deeper into the medulla. The juxtamedullary ones tend to have longer proximal convoluted tubules. And the tubule itself isn't uniform all the way along, is it? It has different segments.
That's right, it does. It's commonly divided into S1, S2, and S3 segments. The very beginning, the S1 segment, is uniquely equipped for transport. Think of it like the kidney's primary high-capacity vacuum cleaner.
High-capacity vacuum cleaner, I like that.
Its cells have this dense brush border of microvilli on the side facing the filtrate, which massively increases surface area. They're packed with mitochondria, the cell's power generators, and have intricate folds in their membranes to cram in transport machinery. This gives the S1 segment the highest capacity for rapidly transporting things like sodium, other solutes, amino acids, glucose, and fluid back into the body.
Okay, so S1 is built for heavy lifting right at the start. What kind of volume are we talking about? How much gets reclaimed there?
A tremendous amount. About 65% of that initial filtered water is reabsorbed right there in the proximal tubule.
65%, wow.
Yeah, along with the majority of important ions, nearly all the glucose and amino acids that were filtered, and significant amounts of bicarbonate. It's where the most aggressive reclaiming happens.
And this reabsorption happens in a balanced way, isosmotic reabsorption you mentioned, where solutes and water are pulled back proportionally. How does the water follow the solutes so efficiently?
That's a good question, and there are different views. But one leading hypothesis suggests a small osmotic gradient develops the fluid inside the tubule, becomes just slightly less concentrated, just slightly hypotonic, compared to the surrounding tissue fluid.
Just a tiny difference.
A very small difference, yeah. But that tiny osmotic difference is thought to be enough to drive a significant portion, maybe around 50% of the water movement, pulling it across the tubule cells via the transcellular route.
So a subtle difference creates a big movement of water.
Interesting. What about glomerular tubular balance? That sounds like the filtration rate and tubule reabsorption are somehow linked? They are, and it's a remarkable bit of autoregulation. Glomerular tubular balance describes how the proximal tubule adjusts its reabsorption rate based on how much filtrate is actually coming through from the glomerulus.
Okay. How?
The hypothesis is that if more filtrate flows in, meaning a higher GFR, it brings more filtered substances like sodium bicarbonate, glucose, and amino acids to the tubule. These substances themselves, presented at a higher rate, stimulate the tubule cells to reabsorb proportionally more.
So it automatically adjusts its vacuum power based on how much stuff is coming down the pipe. It matches the load.
Exactly. It helps maintain a stable fractional reabsorption despite normal variations in GFR. It's a crucial balancing mechanism. We also see hormones influencing this segment. Angiotensin II, which is a key player in blood pressure regulation.
Right, part of RAAS.
Exactly, part of the renin-angiotensin-aldosterone system. Angiotensin II stimulates the secretion of hydrogen ions here in the proximal tubule. This is important for reclaiming bicarbonate ions, which helps maintain acid-base balance.
Good to know which hormones are active early on in the tubule.
And just a note, related to hormones, while angiotensin II stimulates transport here, atrial natriuretic factor, or ANF, another hormone involved in fluid balance, does not seem to inhibit these basal or angiotensin II stimulated processes in the proximal tubule. That action happens later.
Okay, so ANF doesn't play a direct role here. Good clarification. You mentioned angiotensin II stimulates secretion, and the tubule reclaims things. How exactly do substances cross from the filtrate back into the blood, or for that matter, get secreted from the blood into the filtrate? What are the pathways?
Right, that happens via two main routes across the tubule wall, across that epithelial layer. There's the transcellular route and the paracellular route.
Okay, let's start with transcellular. What does that mean?
Imagine the tubule cells lining the wall are like tiny houses built right next to each other. The transcellular route means a substance travels through the cell, through the house.
Through the house.
Yep. It crosses the membrane facing the filtrate, that's the apical membrane, moves across the inside of the cell, the cytosol, and then exits across the membrane facing the blood, an interstitial fluid that's the basolateral membrane.
So it goes in one side of the cell and out the other.
Exactly. This route is required for active transport moving substances against their concentration gradient, which needs energy, either directly from ATP or indirectly using an existing gradient. And importantly, secretion moving stuff from the blood into the filtrate always uses this transcellular route because it's often an active process. Passive movement down a gradient can also use this route for some things.
Okay, that's transcellular. And the paracellular route.
That's like squeezing between the houses. Substances move through the tight junctions that connect the cells, sort of slipping between them, right into the space between the cells, and eventually reaching the capillaries.
Ah, between the cells.
Yeah. This route is purely passive. It requires no energy from the cells and relies only on diffusion or osmosis, moving down existing concentration or electrochemical gradients.
Okay, through the cell versus between the cells. Transcellular versus paracellular. That clarifies how things get moved around. Now let's talk about the kidney's absolutely vital role in something we might take for granted. Keeping the body's pH, its acid-base balance, stable.
Oh, absolutely critical. The kidneys are master regulators of the pH of our extracellular fluids. If our blood gets too acidic or too alkaline, cellular processes just can't function correctly. It's a very narrow range.
And they do this by managing hydrogen ions and bicarbonate, right? Acid and base.
Exactly. They fine-tune how many hydrogen ions, H+, which are acidic, and how many bicarbonate ions, HCO3, which are alkaline or basic, are reabsorbed back into the blood or secreted into the filtrate to be excreted. As we touched on, the proximal tubule plays a big role by secreting hydrogen ions, which is coupled to reclaiming bicarbonate. But further down, in the late distal tubule and the collecting system, there are special cells called intercalated cells.
Intercalated cells.
Yes. These cells are really good at actively pumping hydrogen ions into the filtrate. This process is particularly stimulated by the hormone aldosterone. They can actually concentrate those hydrogen ions in the forming urine quite significantly, making urine acidic.
So they can really pump out the acid to protect the body's bicarbonate reserves. How does the kidney respond specifically if the blood becomes too acidic, say, during metabolic acidosis?
This is a beautiful mechanism. When blood pH drops, certain enzymes within the tubule cells get activated. They take an amino acid, glutamine, from the blood and essentially process it. This generates two key things: ammonia, NH3, and new bicarbonate ions, HCO3.
Okay.
The ammonia is secreted into the filtrate. There, it acts like a buffer. It readily binds with the excess hydrogen ions to form ammonium, NH4+, which is then excreted in the urine. This effectively traps and removes acid. And critically, the bicarbonate ions generated in this process are transported back into the blood.
So it generates new base to replenish what's been lost, buffering the acid in the blood.
Exactly. It's like a built-in bicarbonate factory and acid neutralizer, all in one.
Very clever. What if the opposite happens? What if the blood becomes too alkaline?
The kidney responds by basically doing less of the opposite. The tubule cells will reabsorb fewer bicarbonate ions from the filtrate. More bicarbonate stays in the filtrate, gets excreted in the urine, and this loss of base helps to lower the blood pH back down towards the normal range.
A sophisticated balancing act indeed, just constantly adjusting. So the filtrate is passed through the proximal tubule, the loop of Henle, which we know is crucial for concentrating urine, though we didn't dive deep there based on our plan, and the distal tubule. Where does it go next?
It enters the collecting system. This isn't part of the nephron itself, but it's where filtrate from multiple nephrons converges. It starts with cortical collecting ducts in the outer part of the kidney, the cortex. These merge together, forming larger medullary collecting ducts that run down through the inner part, the medulla. These finally converge into even larger papillary ducts that exit at the very tip of the renal pyramid.
And the cells lining these tubes, they change as you go deeper into the kidney.
Yes, they do. They transition from a simple cuboidal shape in the cortical collecting ducts to a low columnar shape in the papillary ducts.
At what point is the fluid officially called urine? When does it stop being filtrate?
Good question. It's generally considered urine once it reaches the end of the papillary duct. From there, it drips out of the opening at the papilla into a minor calyx.
A minor calyx.
Yeah, it's like a little cup-shaped structure that collects the urine from a single renal pyramid.
And speaking of that collecting system, those tubules, is that where kidney stones commonly form?
Yes, that's a common sight. Often within these collecting system tubules or the calyces themselves, crystals can precipitate out of the urine and grow, potentially forming a stone that can block the flow of urine.
Ouch. That blockage causes the intense pain, right?
Exactly. Renal colic.
You mentioned the medullary collecting ducts running through the medulla. Do they have special properties related to water handling?
They are absolutely key to the kidney's ability to produce concentrated urine. Their permeability to water is entirely controlled by a hormone called ADH, antidiuretic hormone.
ADH, okay.
Without ADH present, the walls of these medullary collecting ducts are practically impermeable to water. The water just stays trapped inside the tubule. But with ADH present, they become highly permeable to water. This allows large amounts of water to be reabsorbed from the filtrate, moving out into the very salty interstitial fluid of the medulla, thus concentrating the remaining urine significantly. These ducts are also permeable to urea, interestingly. Some urea moves out into the interstitium down its concentration gradient, and this actually helps build and maintain that high osmotic gradient in the medulla that's needed to pull water out.
That brings us perfectly to hormonal orchestration, particularly for that final fine-tuning of water and ion balance in the distal tubule and collecting system. Aldosterone and ADH seem like the main players here, regulating that final output.
They absolutely are. They work together, often as part of that RAAS system, to regulate blood volume, blood pressure, and electrolyte balance. Aldosterone, which is released from the adrenal cortex,
Right, at top of the kidney.
acts primarily on the late distal tubule and the collecting system. Its main job is to stimulate the reabsorption of sodium ions, Nas+. It tells the cells to pull more sodium back into the blood.
Reclaiming more sodium.
Yes. And as sodium is pulled back into the blood, potassium ions, K+, and hydrogen ions, H+, are secreted into the filtrate. It's often a swap. Now, critically, as sodium moves back into the body, water and chloride ions, the CLA, can passively follow, but only if the membrane is permeable to water at that point.
And that's where ADH comes in, to control the water permeability.
Exactly. Aldosterone sets up the sodium gradient, but ADH determines if water follows. ADH, antidiuretic hormone, also called vasopressin, is produced up in the hypothalamus and released from the posterior pituitary gland. Its name tells you what it does. Antidiuresis means it reduces urine output, helping the body retain water.
How does it do that? How does it make the tubules permeable?
ADH works by causing little water channels called aquaporins, specifically aquaporin 2, to be inserted into the apical membranes, the filtrate-facing side, of the cells in the late distal tubule and the collecting ducts.
Water channels, like tiny pores.
Exactly. Think of them as gates for water. In the absence of ADH, these gates are mostly kept inside the cell, and those tubule segments are barely permeable to water. When ADH is present, it signals the cells to move these aquaporin gates to the surface membrane, dramatically increasing the cell's water permeability.
Okay.
This allows water to rapidly leave the filtrate and move into the hyperosmotic medullary interstitium by osmosis, following the gradient created by solutes like sodium and urea.
So ADH is the signal. Conserve water, open the water gates.
Precisely. It's essential for concentrating urine and preventing dehydration.
And these hormones, aldosterone and ADH, They're influenced by that larger renin-angiotensin-aldosterone system, RAAS, we mentioned. Angiotensin II is a big player there too, right?
A very big player. Angiotensin II has widespread effects. It's a powerful vasoconstrictor, meaning it narrows blood vessels. A particularly clever move is that it constricts the efferent arterioles, the tiny blood vessels, leaving the glomerulus often more than the afferent arterioles bringing blood in.
Constricting the exit, why would it do that? What's the benefit?
It's like putting a thumb partially over the end of a garden hose. By restricting outflow from the glomerulus, it builds up pressure inside the filtering unit, the glomerular capillaries.
Ah, raises the filtration pressure.
Exactly. This helps maintain the glomerular hydrostatic pressure and keeps the GFR up, ensuring filtration continues effectively, even if systemic blood pressure happens to be a bit low. Angiotensin II also constricts systemic blood vessels, which raises overall blood pressure, and it's the key signal stimulating the adrenal gland to release aldosterone.
It's all connected.
And don't forget the macula densa cells we mentioned earlier, sensing the filtrate flow and composition in the distal tubule. They provide feedback to the juxtaglomerular cells right next to the glomerulus, signaling them to adjust renin release, which kicks off the RAS cascade, and also directly influencing the tone of the afferent and efferent arterioles to help autoregulate GFR.
It's an incredibly intricate feedback loop designed to keep filtering blood effectively and maintain blood pressure and volume. Amazing. Okay, so the filtrate has been meticulously processed, fine-tuned, concentrated. It's now officially urine, exiting the papillary duct. Where does it go from that minor calyx, that little cup?
The minor calyces, typically several of them, join up to form larger collecting funnels called major calyces. These major calyces then merge together to create the renal pelvis, which is essentially a large funnel-shaped basin right inside the kidney within the area called the renal sinus.
Okay, the renal pelvis.
From the renal pelvis, the urine flows out of the kidney and enters the ureter.
Which takes us out of the kidney itself and down into the lower urinary tract.
Exactly. The ureters are muscular tubes, one from each kidney. They use waves of smooth muscle contraction called peristalsis.
Like squeezing a tube of toothpaste.
Pretty much, yeah.
Yeah.
To actively propel the urine downwards from the kidneys to the urinary bladder for storage.
As the bladder, our storage tank, what's that like inside?
The urinary bladder is a hollow, muscular, and quite distensible organ. Its wall has typically 3 layers. An inner lining of specialized transitional epithelium, also called urothelium, which is amazing because it can stretch significantly as the bladder fills.
Transitional epithelium, okay.
Then there's a thick middle layer composed mainly of smooth muscle, collectively called the detrusor muscle. This is the muscle that contracts forcefully to empty the bladder during urination. And finally, there's an outer layer of connective tissue, the adventitia. At the base of the bladder on the internal surface, there's a triangular area called the trigone.
The trigone.
Yes, it's defined by the openings of the 2 ureters entering from above and the single opening of the urethra exiting below. It's a relatively smooth area compared to the rest of the bladder lining, which has folds called rugae when empty.
And the bladder's position is slightly different in males and females, you mentioned.
Yes, anatomically it is. In males, the bladder sits just anterior to the rectum. In females, it's situated anterior to the vagina and lies inferior to the uterus.
Okay. From the bladder, urine exits the body via the urethra.
Correct. The urethra is the final tube that drains urine from the bladder neck out of the body. Like the bladder, it has muscular and connective tissue layers lined with a protective mucous membrane. Its opening from the bladder is guarded by 2 important sphincters that control the release of urine.
Right. The internal and external sphincters. How do they work? What's the difference?
The internal urethral sphincter is located right at the junction of the bladder and the urethra. It's made of smooth muscle, so its action is involuntary. You can't consciously control it. It's normally contracted to prevent urine leakage between voidings.
Okay. Involuntary internal.
Further down, surrounding the urethra as it passes through the pelvic floor muscles, is the external urethral sphincter. This one is composed of skeletal muscle, specifically part of the levator ani muscle group. Because it's skeletal muscle, this sphincter is under your conscious, voluntary control.
Ah, so that's the one you consciously relax when you decide to urinate.
Exactly. And it's worth noting, there's no third sphincter right at the external opening of the urethra.
Okay, involuntary, internal, voluntary, external. Makes sense. And there's a significant length difference between the sexes here too, right?
Yes, a major difference. The male urethra is much longer, typically around 20 centimeters, because it has to pass through the prostate gland and the entire length of the penis. It serves a dual function in males, acting as a passageway for both urine and semen during ejaculation.
Whereas the female urethra.
The female urethra is much shorter, usually only about 4 centimeters long. It opens anterior to the vagina and serves solely for the passage of urine. This shorter length is one reason why urinary tract infections, UTIs, are generally more common in women.
That leads us logically to the process of actually emptying the bladder micturition or urination. How does that reflex work? It feels automatic, but also controllable, usually.
It's a fascinating coordinated reflex involving both involuntary and voluntary components controlled by the nervous system. As the bladder fills with urine, stretch receptors embedded in the bladder wall become activated. They send signals via sensory nerves up the spinal cord.
Okay, signals going up.
These signals do a couple of things. They go to spinal cord interneurons that control the involuntary internal sphincter and the detrusor muscle. But crucially, they also travel up to the micturition center located in the pons, which is part of the brainstem. This input to the pons is what generates the conscious sensation or urge to urinate.
And then our brain or higher centers decide if it's the right time and place.
Precisely. If the cerebral cortex determines that the time and place are appropriate for urination, it sends signals down that essentially permit the reflex to proceed. This involves relaxing the voluntary external urethral sphincter. Simultaneously, the parasympathetic signals, facilitated by the pons, cause the detrusor muscle to contract strongly, and the internal sphincter also relaxes, opening the bladder neck. The combination allows urine to flow out.
And if it's not appropriate, if you need to hold it.
Then the cerebral cortex sends inhibitory signals. It keeps the external urethral sphincter contracted and suppresses the contraction of the detrusor muscle. The internal sphincter remains closed. The urge to void usually subsides temporarily, but it will typically return, often stronger, within an hour or so as the bladder continues to fill.
How full does the bladder typically get before that voluntary control becomes really challenging to maintain?
It varies, but usually around 500 to 600 milliliters of urine accumulation. At that point, the stretch signals are very strong, and consciously overriding the involuntary reflex to empty becomes much more difficult.
We've journeyed through the healthy kidney and the urinary tract, understanding its incredible complexity and its amazing ability to maintain balance, homeostasis. Now, though, we have to shift gears and talk about what happens when this master system starts to fail, and how you, as a dialysis nurse, step into that gap.
Yes, this is where renal replacement therapy, most commonly dialysis, becomes necessary. Dialysis is essentially a method to supplement or, in cases of complete failure, replace the kidney's vital job of filtering the blood. Its purpose is to remove excess fluid, electrolytes like potassium and phosphate, and accumulated metabolic toxins like urea from the body.
So the fundamental goal is really to restore or maintain that delicate internal balance, that homeostasis that the healthy kidney normally provides.
Precisely. It's absolutely essential for patients who develop acute kidney injury, or AKI, that's a sudden loss of kidney function, or for those with chronic kidney disease, CKD, which is a long-term progressive loss of function. CKD used to be commonly referred to as ESRD, end-stage renal disease, when it reached the point of needing dialysis or transplant. Dialysis can be a temporary measure, maybe during AKI recovery or as a bridge to kidney transplant, or it can be a lifelong maintenance treatment for those with permanent kidney failure.
And CKD requiring dialysis is a major and unfortunately growing global health challenge, isn't it?
It is, yes. The burden is significant. And a large majority of cases leading to dialysis are linked to just 2 very common underlying conditions. Diabetes mellitus accounts for roughly 45% of cases.
Nearly half.
And hypertension, or high blood pressure, accounts for about another 30%. So managing those underlying conditions effectively is critical for prevention. But once kidney failure occurs, dialysis is often the lifeline.
And there are different ways to perform dialysis, different types.
Yes. The main types you'll encounter are hemodialysis, peritoneal dialysis, and hemofiltration, which is often used in critical care settings, sometimes called CRRT, or continuous renal replacement therapy.
We're going to focus primarily on hemodialysis today, as that's the most common type you'll be dealing with directly in an outpatient or inpatient dialysis clinic setting. How many patients in the U.S. rely on it? It must be a lot.
It is a substantial number. Approximately 430,000 patients in the United States depend on hemodialysis for survival.
430,000. Wow. And for hemodialysis, getting blood out of the patient's body through the machine and back in safely and efficiently is absolutely critical. What are the options for vascular access?
Vascular access is truly the lifeline for hemodialysis patients. Its function dictates the quality of dialysis they receive and often their quality of life. While temporary venous catheters can be used, especially when starting dialysis urgently, the preferred long-term options require a minor surgical procedure. The gold standard is an arteriovenous fistula, or AVF. This is created by directly connecting one of the patient's own arteries, usually in the arm, to a nearby vein.
Connecting an artery to a vein.
Yes. This allows high-pressure arterial blood to flow into the vein, causing the vein to enlarge and thicken over time, a process called maturation. This creates a durable access point with high blood flow rates suitable for dialysis needles. The other main option is an arteriovenous graft, or AVG. This involves using a synthetic tube, a graft to connect an artery and a vein.
Okay, officially uses native vessels. A graft uses a synthetic tube. Is one better?
Generally, the AVF is preferred. It tends to last longer and has a lower risk of complications like infection and clotting compared to AVGs or catheters. However, fistulas take time to mature, sometimes months, whereas grafts can often be used sooner. The choice depends on the patient's individual anatomy and clinical situation.
So creating a robust access point is step one. Once that access is established and ready, what's the actual hemodialysis technique? How does it work?
Okay, so you use the hemodialysis machine to pump the patient's blood out of their body, usually via needles inserted into their fistula or graft. This blood flows through plastic blood lines to a specialized filter called a dialyzer. This is often referred to as the artificial kidney.
A dialyzer.
Inside the dialyzer, the blood flows through thousands of tiny hollow fibers made of a semi-permeable membrane. The machine then pumps the clean blood back to the patient through another needle. Blood flow rates through this circuit are typically quite high, maybe 300 to 500 milliliters per minute, to process enough blood during the treatment time.
Okay, blood goes through the filter. What happens on the other side of that membrane? Simultaneously, a specialized fluid called dialysate is pumped through the compartment surrounding the blood-filled fibers inside the dialyzer. Crucially, the dialysate flows in the opposite direction to the blood flow.
Opposite direction. Why is that important? Why counter-current flow?
That's called counter-current flow, and it's key for efficiency. By having the fresh dialysate flowing counter to the blood, you maintain the steepest possible concentration gradient for waste products all along the length of the dialyzer membrane.
Keeps the difference as big as possible.
Exactly. This maximizes the efficiency of diffusion, the primary way waste products are removed from the blood into the dialysate.
Okay, so diffusion is one way solutes move.
Yeah.
How else do things get cleared? There are two primary mechanisms of solute removal across that semi-permeable membrane. The first, as we said, is diffusive clearance. This is simple passive diffusion driven by concentration gradients. Waste products like urea, creatinine, potassium phosphate, they're all at high concentration in the patient's uremic blood and at a very low or zero concentration in the fresh dialysate. So they naturally move across the membrane down their gradient from blood to dialysate. Smaller molecules, like urea, move faster and more easily via diffusion than larger ones.
Okay, diffusion pulls the waste stuff out because there's less of it in the dialysate.
Yeah.
What's the second mechanism?
The second is convective clearance, sometimes called solvent drag. This is linked to fluid removal. When you remove excess fluid from the patient's blood during dialysis, a process called ultrafiltration, which is a key goal for most patients, that movement of water across the membrane actually drags some solutes along with it.
So the water pulls solids with it as it leaves the blood.
Exactly. It's like the water flow is sweeping some solutes across the membrane. Convection is particularly important for removing larger middle molecules that don't diffuse as readily.
Got it. Diffusion based on concentration difference, convection based on water movement pulling solids along. What's actually in that dialysate fluid that's flowing on the other side?
The dialysate is very carefully composed. It starts with highly purified water. Removing contaminants is critical. To this water, precise amounts of electrolytes are added to create concentrations similar to or targeted towards normal plasma levels. This includes ions like sodium, potassium, calcium, magnesium, chloride, and crucially, a buffer, usually bicarbonate, to help correct the metabolic acidosis common in kidney failure. It also usually contains some dextrose or glucose.
And why the dextrose?
It helps prevent excessive glucose loss from the blood into the dialysate and can contribute slightly to the osmotic gradient for fluid removal. But the key thing is what's not in the dialysate. It has very low or zero concentration of the waste products like urea, creatinine, and phosphate that you want to remove from the patient's blood. The specific electrolyte concentrations like potassium and calcium are prescribed by the nephrologist and tailored to the individual patient's needs and lab values.
Okay, so the dialysate provides the good stuff and lacks the bad stuff to create those gradients. And how do you achieve that fluid removal you mentioned, the ultrafiltration? How do you pull the excess water out?
Ultrafiltration is achieved by creating a pressure gradient across the dialyzer membrane. The dialysis machine applies negative hydrostatic pressure to the dialysate compartment.
Negative pressure, like suction.
Essentially, yes. This creates a pressure difference, the transmembrane pressure, or TMP, where the pressure is higher on the blood side than the dialysate side. This pressure gradient physically pushes water out of the blood, across the membrane pores and into the dialysate, which is then discarded. The machine carefully controls this pressure to remove the prescribed amount of fluid over the course of the treatment.
Okay, so you're cleaning the blood via diffusion and convection, driven by concentration gradients, and removing excess fluid via ultrafiltration, driven by a pressure gradient. What are the targets for a typical dialysis session? How do you know if the treatment was adequate?
That's a key question in dialysis management. Adequacy is often assessed using measures that reflect the clearance of small solutes, most commonly urea. The urea reduction ratio, or UR, measures the percentage drop in the patient's blood urea nitrogen, BUN level, from before to after the dialysis session. Typically, the target is a URR of at least 65%, ideally closer to 70% or higher.
Okay, URR for urea clearance.
Another related measure is KTV urea, which is more complex calculation factoring in the dialyzer clearance, K, treatment time T, and the patient's total body water volume, V. A minimum target KTV is often set, like 1.2 per treatment for 3 times weekly hemodialysis. But it's really important to remember that dialysis adequacy isn't just about hitting a urea clearance number. The dose of dialysis needs to be individualized.
Oh, so.
It has to consider the patient's overall clinical status, how much fluid needs to be removed to reach their target dry weight, how well their electrolytes, particularly potassium and phosphorus, are controlled between treatments, and how well their acid-base balance, reflected by bicarbonate levels, is managed. Achieving adequate fluid removal without causing severe cramping or hypotension is just as crucial as hitting a URR target.
So it's a multifaceted goal, really focused on the whole patient, not just hitting one specific lab number. Are there other preferences or considerations regarding the dialysate composition beyond just getting the ions right?
Yes, definitely. For instance, bicarbonate buffered dialysate is now the standard and strongly preferred over older acetate buffered solutions. Acetate could sometimes cause problems like vasodilation and hypotension, especially in unstable patients. We also increasingly use online monitoring systems built into modern dialysis machines. These can measure things like blood temperature, relative blood volume changes, or even dialysate ionic clearance during the session itself.
Real-time monitoring.
Yes, and this allows for potential automatic adjustments. For example, the machine might adjust the ultrafiltration rate profile or the dialysate temperature based on blood volume changes to try and improve hemodynamic stability and reduce symptoms like cramping or low blood pressure during the treatment. And the dialysate calcium concentration is another critical parameter. It needs to be carefully chosen because it directly impacts the patient's serum calcium level, their hemodynamic stability during dialysis, and can influence cardiac function and bone health long term.
That makes sense. The fluid you're exchanging directly with the patient's blood for hours has to be very precisely controlled and monitored. As a dialysis RN, you're right there at the bedside, monitoring the patient closely throughout the entire treatment, which can last 3-4 hours or more. What are some of the common or perhaps critical challenges and complications you'll need to watch out for and manage?
Oh, you'll encounter many potential issues. It requires constant vigilance. One complication often seen when a patient first starts dialysis or if they miss treatments and become very uremic is dialysis disequilibrium syndrome, or DDS.
Disequilibrium syndrome. What causes that and what does it look like clinically?
It happens when urea is removed from the blood much faster than it can be cleared from the brain tissue and the cerebrospinal fluid, CSF. Remember, urea crosses the blood-brain barrier relatively slowly. This creates a temporary osmotic gradient. The urea concentration becomes significantly lower in the blood than in the brain cells. Because water follows solute, water moves osmotically from the blood into the brain cells.
So the brain tissue actually swells slightly.
Exactly. This causes cerebral edema and leads to increased intracranial pressure. The symptoms can range from relatively mild things like headache, nausea, restlessness, or muscle twitching, to much more severe neurologic deterioration, including confusion, seizures, or even coma in rare extreme cases.
That sounds serious. How do you prevent or manage it?
Prevention is key, especially for new patients or those at high risk. You typically start with shorter, less efficient dialysis treatments initially using lower blood flow or dialysate flow rates, or a smaller dialyzer to remove urea more gradually. Sometimes osmotic agents like sodium or mannitol might be added to the dialysate or hypertonic saline given intravenously to counteract the osmotic shift and keep water from moving into the brain too rapidly. Careful monitoring of the patient's neurological status is vital.
Okay, DDS critical to be aware of, especially with new patients. What about reactions to the dialyzer itself, the artificial kidney?
Yes, dialyzer reactions can occur. They're broadly classified into two types, type A and type B. Type A reactions are immediate, severe hypersensitivity, or anaphylactic reactions. Historically, these were often linked to ethylene oxide, ETO, which was used to sterilize some dialyzers, or sometimes to the membrane material itself.
Anaphylactic, like an allergic reaction.
Exactly. These are medical emergencies. Symptoms typically start within the first 5 to 30 minutes of treatment and can include difficulty breathing, dyspnea, a feeling of warmth or impending doom, intense itching, pruritus, hives or urticaria, abdominal cramps, or even cardiovascular collapse.
What's the management?
Stop the dialysis treatment immediately. Do not return the blood and the lines to the patient. Provide supportive care, administer antihistamines, corticosteroids, and potentially epinephrine if it's severe anaphylaxis. Prevention involves using dialyzers sterilized by methods other than ETO if a patient is sensitive, and always ensuring the dialyzer and blood lines are thoroughly rinsed according to protocol before connecting the patient.
Okay, that's type A. What about type B?
Type B reactions are generally less severe and more common, often described as nonspecific or pseudoallergic. They might be related to activation of the complement system, part of the immune response, triggered by contact of the blood with the dialyzer membrane material. Symptoms usually appear a bit later in the treatment, maybe 20 to 40 minutes in, and often manifest as chest pain or back pain. They tend to be self-limiting. Management usually involves supportive care and often simply trying a different type of dialyzer membrane material, for example, switching from cellulose-based to synthetic, for subsequent treatments can resolve the issue.
Hemolysis, the breakdown of red blood cells during treatment sounds like another potential emergency.
It absolutely is an acute medical emergency if it occurs during dialysis. It can be caused by several things related to the dialysis circuit or dialysate, like overheating of the dialysate, contamination with chemicals like chlorine or copper, kinking of the blood lines causing shear stress, or incorrect dialysate composition, e.g. hypotonic dialysate.
How would you recognize it?
You might visually spot it. The blood returning to the patient in the venous bloodline might take on a translucent port wine or a cherry red appearance instead of its normal opaque dark red color. The patient might complain of symptoms like shortness of breath, chest or back pain, or abdominal cramping. Lab tests would show a rapid drop in hematocrit and hemoglobin, and the patient's plasma, if spun down, would look pink or red due to free hemoglobin.
What's the immediate action?
Stop dialysis immediately. Clamp the blood lines, do not return the blood, as it contains damaged cells and high levels of potassium released from the fixulated cells. Assess the patient, provide supportive care, and investigate the cause. Check the dialysate temperature and composition, inspect the lines for kinks. It requires urgent medical attention.
An air embolism, the risk of introducing air into the patient's bloodstream.
This is a rare but potentially fatal complication. It's absolutely crucial to prevent it through meticulous attention to connecting and disconnecting lines, ensuring air detectors on the machine are functioning correctly, and managing venous pressures appropriately.
What are the signs if it does happen?
Signs include visible air or foam in the venous bloodline, especially downstream of the air detector. The patient might suddenly develop shortness of breath, coughing, chest pain, cyanosis, bluish discoloration, confusion, or loss of consciousness. You might hear a characteristic churning or mill wheel murmur if you listen over the heart with a stethoscope.
What's the emergency management?
Immediate, decisive action is vital. Stop the blood pump immediately. Clamp the blood lines, particularly the venous line, to prevent any more air from reaching the patient. Position the patient urgently on their left side with their head down, Trendelenburg position. This is called the Durant maneuver, and the goal is to trap the air in the apex of the right ventricle, preventing it from entering the pulmonary circulation where it could cause a fatal blockage. Administer 100% oxygen. Call for immediate medical assistance. If central venous access is available, attempting to aspirate the air might be considered.
Wow. Those are definitely critical emergencies requiring rapid recognition and response. What about the more general but still uncomfortable or common issues patients might experience during a typical treatment?
Right. Beyond the rare emergencies, there are common nonspecific complications. Nausea and vomiting are frequent. Headache is common. Muscle cramps, especially in the legs or abdomen, can be quite bothersome, often related to rapid fluid removal or electrolyte shifts. Some patients experience chest pain or back pain, which might be related to type B reactions or sometimes just musculoskeletal. Itching or pruritus can also occur during or after treatment.
And what's often the underlying cause for many of these?
Many of these nonspecific symptoms, particularly nausea, vomiting, headache, and cramping, are frequently related to intradialytic hypotension. That is, blood pressure dropping too low during the dialysis session. This is often caused by removing fluid faster than the patient's body can replenish the vascular volume from the interstitial space, or removing more fluid than necessary.
So the first step is often to address the hypotension.
Yes. Management involves slowing or temporarily stopping ultrafiltration, administering saline if needed, adjusting the patient's target dry weight if they seem consistently volume depleted, and potentially using techniques like blood volume monitoring or adjusting dialysate sodium or temperature profiles to improve hemodynamic stability. For specific symptoms, antiemetics can be used for nausea or analgesics for pain. Persistent itching might sometimes be helped by switching dialyzer membranes or optimizing phosphate and calcium control.
Vascular access dysfunction issues with the fistula or graft, you mentioned this, is a huge issue.
It's arguably the most frequent challenge you'll deal with on a daily basis in the dialysis unit, and it's a major determinant of a patient's ability to receive adequate dialysis and their overall quality of life. The Achilles heel of hemodialysis, some call it. The most common problem is stenosis, which is a narrowing of the blood vessel, either the vein used for the fistula or the graft itself, or the outflow vein. This narrowing reduces blood flow through the access and significantly increases the risk of the access clotting off completely, which is thrombosis.
What would you, as the RN, look for? What are the warning signs?
You assess the access meticulously at the beginning of every single treatment. You should normally feel a palpable vibration called a thrill, and hear a continuous low-pitched swooshing sound called a bruit over a healthy, well-functioning AV fistula or graft.
Thrill and bruit. Okay.
Changes in the quality of the thrill or bruit, like it becoming weaker, higher-pitched, or disappearing altogether, are red flags for stenosis. Other signs include difficulty cannulating the access, inserting the needles, needing unusually high pressure to return the blood, prolonged bleeding from the needle sites after removal, or consistently low blood flow rates achievable during the dialysis treatment despite machine adjustments. Physical signs like swelling of the access arm can also indicate outflow problems.
And what's done if stenosis or thrombosis is suspected?
Prompt intervention is crucial. If it's stenosis, the patient is usually referred for an imaging study, like an ultrasound or fistulogram, an X-ray with contrast dye, to identify the location and severity of the narrowing. Treatment often involves an interventional radiology procedure called angioplasty, where a balloon is inflated inside the vessel to stretch it open, sometimes with placement of a stent. If the access clots off completely, thrombosis, sometimes clot-dissolving drugs like alteplase or urokinase can be used, or a procedure called thrombectomy, stripping the clot out, might be attempted. If these fail, surgical revision or creation of new access may be necessary.
And patient education about protecting their access must be absolutely critical.
Absolutely constant reinforcement. As the RN, you educate patients repeatedly. No tight clothing, watches, or jewelry on the access arm. Avoid carrying heavy items or sleeping on the access arm. Critically, never allow blood pressure measurements or routine blood draws, phlebotomy from the access arm, as this can damage it or lead to clotting.
Needles too, right?
Yes, proper needle insertion technique is vital. For AV fistulas, it's important to rotate needle insertion sites systematically along the length of the fistula, the rope ladder technique, to prevent weakening the vessel wall and aneurysm formation. For grafts, rotation is also important. And after needle removal at the end of treatment, applying firm but not excessive pressure directly over the sites until bleeding stops completely is essential, followed by a clean dressing.
Bleeding is another risk, isn't it? Especially given the necessary use of anticoagulation like heparin during treatment.
Yes. Heparin is routinely used during hemodialysis to prevent the blood from clotting within the dialyzer and blood lines. While necessary, it does increase the risk of bleeding, particularly from the needle puncture sites after the needles are removed. Bleeding from the sites after treatment is a common issue. It's managed initially with firm but gentle direct pressure using gauze. Holding pressure for 10-15 minutes or sometimes longer is often required. If bleeding is persistent or excessive, the anticoagulant effect of heparin can be reversed using protamine sulfate, although this is used cautiously. Patient education is key here too, teaching them how to apply pressure effectively themselves at home if minor oozing occurs, and importantly, when they need to seek immediate medical help if bleeding doesn't stop or seems excessive.
And electrolyte imbalances. Dialysis is supposed to fix them, but can the treatment itself sometimes cause issues?
Precisely. While dialysis is the primary treatment for correcting the severe electrolyte imbalances common in kidney failure, particularly hyperkalemia, high potassium, hyperphosphatemia, high phosphorus, and metabolic acidosis, low bicarbonate imbalances can still occur, or even be exacerbated during the treatment itself if the dialysate composition isn't appropriately matched to the patient's needs, or if rapid shifts occur. Hyperkalemia remains probably the most common and clinically significant acute electrolyte emergency you'll face, especially in patients who are non-compliant with their dietary potassium restrictions between treatments. Dialysis removes potassium, but if levels are dangerously high pre-dialysis, cardiac monitoring is crucial. Other potential issues include hypermagnesemia if dialysate magnesium is too high, hyponatremia, low sodium, or hypernatremia, high sodium, if dialysate sodium isn't right or fluid shifts are extreme, or hypocalcemia, low calcium, or hypercalcemia, depending on the dialysate calcium concentration and the patient's underlying bone disease status. Constant monitoring and adjustment are needed.
And sadly, there's a heightened risk of sudden cardiac death in dialysis patients.
Unfortunately, yes. Patients on maintenance hemodialysis, particularly those newly starting treatment, have a significantly higher risk of sudden cardiac death compared to the general population. This is often due to lethal cardiac arrhythmias, like ventricular fibrillation. The reasons are complex and multifactorial. These patients often have underlying cardiovascular disease due to factors like hypertension, diabetes, fluid overload, and electrolyte imbalances. The physiological stresses of the dialysis procedure itself, rapid fluid shifts, electrolyte changes, changes in blood pressure can also contribute to cardiac instability and arrhythmias in susceptible individuals.
Given this incredibly wide range of potential complications, from neurologic issues like DDS to immune reactions, hemolysis, air embolism, access problems, bleeding, electrolyte shifts, and cardiac risks, plus the underlying complexity of kidney failure itself, it's crystal clear that managing dialysis patients isn't and can't be a one-person job.
Absolutely not. Effective dialysis patient management is inherently interprofessional. It truly requires a well-coordinated team approach to address all the medical, nutritional, psychosocial, and technical aspects of care.
Who are the key players on that team?
The nephrologist, the kidney specialist physician, typically serves as the leader of the team, overseeing the patient's overall medical management, prescribing the dialysis treatment, managing complications, and educating the patient about their condition and treatment options. Advanced practice providers, such as experienced dialysis nurse practitioners or physician assistants, often work closely and collaboratively with the nephrologist, managing many day-to-day aspects of patient care.
And the role of the nephrology nurse, the dialysis RN, seems absolutely central to everything that happens during the actual treatment delivery.
Crucial doesn't even begin to cover it. As a nephrology nurse, you are truly on the front lines of patient care in the dialysis unit. You're performing detailed assessments of the patient before, during, and after each treatment. You're administering medications, including heparin and often IV iron or other drugs. You are responsible for setting up and monitoring the dialysis machine and the entire process, cannulating the access, troubleshooting any alarms or problems that arise during the session, and ensuring patient safety throughout. Beyond the technical aspects, you're providing vital patient education, emotional support, and coordinating care. Nephrology nurses are also absolutely essential in home dialysis programs, training patients or their care partners to perform hemodialysis or peritoneal dialysis safely and effectively in their own homes.
It's a hugely demanding and skilled role. Who else rounds out that core team?
The renal dietitian is another vital member. They work with patients to navigate the incredibly complex and often very restrictive dietary and fluid requirements that are essential for managing electrolytes like potassium and phosphorus, controlling fluid balance between treatments, and maintaining adequate nutrition despite appetite changes or restrictions. They tailor meal plans to individual needs and preferences, monitor nutritional status, and play a role in managing related issues like bone disease and anemia.
And the social aspect must be huge for these patients.
Immense. That's where the nephrology social worker comes in. They provide essential psychosocial support, counseling patients and their families as they cope with a significant burden of chronic kidney disease and the demands of dialysis treatment. They help patients navigate lifestyle changes, identify coping strategies and support systems, connect them with community resources like transportation or financial assistance, and work to improve their overall quality of life and adjustment to living with kidney failure.
It truly takes that whole multidisciplinary team working together to provide comprehensive, patient-centered care. Finally, before we wrap up this deep dive, let's just briefly touch on another major threat to kidney function that's directly relevant to your role in medication administration: nephrotoxicity, drug-induced kidney damage.
Yes, that's a really important consideration. Certain medications, unfortunately, can directly damage the kidneys, leading to drug-induced nephrotoxicity. It's estimated that drug toxicity accounts for a significant percentage, maybe around 20%, of all episodes of acute kidney injury, AKI, that occur in hospitalized patients. And it's a leading cause of intrinsic renal failure, meaning damage originating within the kidney itself, perhaps second only to severe infection or sepsis.
Why is it so important for an RN, especially a dialysis RN, caring for patients who might already have compromised kidneys, to be acutely aware of this?
Because you are often the one administering these potentially nephrotoxic medications, and you're monitoring patients closely for any signs of changing kidney function or adverse effects. Awareness is key to prevention and early detection. Drugs can damage the kidney through several different mechanisms. Some primarily alter the kidney's hemodynamics, affecting blood flow and pressure within the glomerulus, which in turn reduces the GFR. Common examples in this category include ACE inhibitors and ARBs, angiotensin receptor blockers, especially if used in patients with bilateral renal artery stenosis, and NSAIDs, non-steroidal anti-inflammatory drugs like ibuprofen or naproxen, particularly in volume-depleted patients.
Okay, so some affect blood flow. What are other mechanisms?
Others cause direct toxicity to the tubular cells themselves, damaging their structure and function. Classic examples here include certain antibiotics, particularly the aminoglycosides like gentamicin or tobramycin, and the antifungal medication amphotericin B. Contrast dye used for imaging can also cause tubular injury. Still, other drugs can cause an inflammatory reaction within the kidney tissue, leading to acute interstitial nephritis, AIN. This is often an allergic-type reaction, and many different drugs have been implicated, including some antibiotics like penicillins, cephalosporins, and proton pump inhibitors, PPIs.
So knowing which drugs carry these risks and carefully monitoring kidney function when they're used is absolutely key.
Absolutely. Standard practice involves assessing baseline kidney function, often using serum creatinine and calculating an eGFR, before starting potentially nephrotoxic medications, especially if a patient already has underlying CKD, perhaps with an eGFR already below that 60 millimole threshold. Monitoring kidney function during and after therapy is also crucial. And thinking back to those newer biomarkers we mentioned earlier, like KM1 for tubular injury and NGAL for AKI, they hold promise for potentially detecting drug-induced kidney damage earlier than traditional measures like BUN or creatinine alone, although they're not yet in routine widespread use everywhere.
We've covered a tremendous amount of ground today. We started with the kidney's protective outer layers, journeyed through the intricate workings of the nephrons filter and its highly specialized tubules, doing that incredible work of reabsorption and secretion. We followed the path through the collecting system and the rest of the urinary tract. Then we shifted to the clinical reality of kidney failure and dove deep into the principles and practice of hemodialysis, the access, the mechanisms of clearance and fluid removal, the crucial goals of adequacy, and the many potential complications you need to anticipate and manage. We also highlighted the vital importance of the interprofessional care team and the risk of nephrotoxic medications.
It really is a complex but incredibly rewarding area of nursing, requiring a deep understanding of both normal physiology and the pathophysiology of kidney failure and its treatment.
So consider this as you move forward in your dialysis RN role. The kidney in its healthy state is a master of exquisite, constant balance, tirelessly adjusting filtration, reabsorption, and secretion second by second to maintain the body's internal environment, its homeostasis. As a dialysis nurse, you are stepping directly into that process when that intricate, natural balance is fundamentally lost. How does truly understanding the normal, the beautiful complexity of the kidney's physiological balancing act inform and shape your clinical assessment, your critical thinking, and your care interventions for a patient whose system can no longer perform that vital function on its own during those critical hours they spend connected to the dialysis machine?
That's a powerful way to frame the importance of this foundational knowledge. It really underscores why understanding the why behind the what we do in dialysis is so critical for providing the best possible care.
Thanks for listening to All in All.